Ladies and gentlemen, dear friends, good afternoon or good morning or good evening, according to where you are living, and thank you of being with us today. It's another webinar of the International Society of Gynecological Endocrinology, which is organized in the meantime, in the waiting time of our next Congress. Today is a fantastic topic, is sexual journey across women age. And we have two stars of this possible scenario, who are Professor Rossella Nappi from Pavia and Professor Sheryl Kingsberg from United States. And today we will speak about impact of medical and reproductive condition, Rossella, and talking sex and treatment approach, Sheryl Kingsberg. As you know, Rossella Nappi is a full professor of obstetrics and gynecology, chief of research center for reproductive medicine and gynecological endocrinology, menopause unit at the San Matteo Foundation, University of Pavia. The major interests of Rossella are psychoneuroendocrinology of female reproductive and post-reproductive life, with special focus on women's sexual health. She published around 350 scientific articles in the peer-reviewed journals and international books, and around 17,500 citations. At present, she is permanent member of the advisory board of the International Society of Gynecology and Endocrinology. It's our pleasure, and the International Academy of Human Reproduction, and she is president-elect of the International Menopause Society. Thank you, Rossella. Please, Sheryl, I will introduce you later on when you will have your talk. Rossella, you have the microphone and the video.
Thank you very, very much. It's a pleasure and honor to be with you today. But most importantly, I will show you in a minute to share this podium with my dear friend, Sheryl Kingsberg. Because before starting, let me give one moment just to introduce this sexual journey with my dear friend Sheryl Kingsberg. I was a little and young gynecologist, as you can see. The first time I met her back in the other century in Boston, and we were both at the Female Sexual Function Forum. And I was there because I realized, being an OBGYN, that sexuality was the Cinderella of medicine, at least in my country at that time. And I wanted to learn more. And in there, I was fascinated, I have to tell you, really, I was fascinated by the deep knowledge of many people that were doing magic things already for sexual health. And one of these people was a very smart psychologist, and we became so much friends. And I think all together, and we hope also the future generation, contribute to turn this Cinderella sexual medicine into a princess. The reason why I approached the sexual medicine at that time was really because I realized that when you discuss reproduction, inevitably you should discuss sexual health. And this not only from a biological perspective, but also from all the other angles that Sheryl will address after my talk. Because we really meet a femininity, so means that sexual function is not the only thing we should consider, but we should consider really identity and role of women. So to be in sexual medicine is to face something that is dynamic and evolving over time in women's life, that brings, in my opinion, nature and nurture. And indeed, in a very simple cartoon, so many years ago, I summarized what I've learned, and I'm still learning, that across the timeline of women's life, and especially across reproductive milestones, you may face different changes in terms of biological factors. Some affect the general health because, you know, how you feel physically, how you feel mentally, the medication you take, lifestyle medicine, how much stress do you have, and most importantly, use of other drugs, street drugs, smoking, alcohol, etc., and together with age, significantly affect sexual life in men, of course, and in women. But in women, most importantly, reproductive events, symptoms, pathologies, and treatment, they may have an impact. And of course, the title of my talk, it's really broad. We will focus our attention on some of these factors because really there is not so enough time to address all the story. First of all, we are in International Society of Gynecological Endocrinology, and this is the other reason why I was interested in sexual medicine, because I strongly believe that the endocrine milieu is the most important factor affecting all the different domains of the physical response and the substrates of our body that perform sexual act and they feel the sexual behavior. Neurovascular substrates, including the central nervous system, of course, central and peripheral, the neuromuscular circuitries, and so a crucial role we were discussing before with Sheryl of the pelvic floor, so the body that act the sexuality, and overall the well-being of the person. And these hormones, they are able to affect the three major domains of the sexual response, just to simplify: the desire, arousal, and orgasmic response, with all the other factors, intrapersonal, interpersonal, modulating this basic response of the body. Some years ago, two very beautiful review articles already pointed out that there are, however, not only hormones, there are many other medical conditions that can affect the sexual function and behavior. And we should devote a webinar to every single domain of this circle that you see on the right part of the slide, because we know it is a crucial issue in cancer patients. In general, we see breast cancer patient, gynecological, oncology, but in every domain of oncology, really, sexual medicine should be there and should be considered a princess and not a Cinderella. Also, chronic pain conditions, they are very relevant. Think about, for example, fibromyalgia, how this condition is comorbid with many female sexual disorder. Some conditions that affect really the body. Think about urinary incontinence, how you can have a satisfactory sexual life if you urinated during orgasm, for example, or in the attempt of penetration. This is something very crucial. And of course, psychiatric and neurological disorder, because the brain is the most active sexual organ, and we know very much how, for example, depression is strongly comorbid with many disorders, in particular hypoactive sexual desire disorder. And last but not least, we have plenty of data, they are growing, suggesting that if you're not healthy from a cardiovascular and metabolic point of view, exactly like it happened in men, you may have some sexual consequences as well in women. But I have to tell you that this is ongoing, but is significantly less studied. So we really need to do more for our patient. Of course, since the endocrine factor is so important, we have more data on other conditions. We have studied very much estrogen deficiency, androgen deficiency, and the role of combined hormonal contraception. A little bit less the role of hyperlactin level, thyroid disorder, metabolic syndrome as a real syndrome together with diabetes and adrenal disorder. I will touch upon some of these aspects. The one I believe they are more relevant and they have more data. I borrowed this cartoon from a wonderful review that Sheryl Kingsberg wrote with another friend of us, Jim Simon, because in one little cartoon, they were able to summarize the most important concept I want to share with you. the fact that testosterone and estradiol, they have a role both at the level of the central nervous system, affecting and promoting desire and arousal into the brain, and so modulating all those neurotransmitters. They are so crucial to stimulate an increasing sexual desire, or to modulating the neuroendocrine threshold for desire, but also that testosterone and estradiol facilitate, and this is something that we know more because we study urogenital medicine, they facilitate the blood flow and vaginal lubrication. But these two dimensions, the brain on one hand and the periphery on the other hand, they always interact to each other. So to be well balanced in terms of testosterone and estradiol, give not only a balance within the brain, but also really within the genital. And one of the mediators is really the same mediator we have studied so much in males. There is nitric oxide, because nitric oxide is the most powerful substance able to vasodilate at the periphery and to increase the blood flow and vaginal lubrication, and promoting the arousal response in the genital, meaning translating what is happening in the brain to the genital and to give origin to all the sensation, congestion, lubrication that is necessary to form the orgasmic platform. What we know from the point of view of hormones and of some pathologies that affect ovulation in women. First of all, we have to consider that there are plenty of evidence in the literature that we, inside ourselves as women, we are still like the animal model, meaning that, of course, we have the cortical, prefrontal cortex, we have emotion, but we have an instinct to sexuality that is modulated by the hormonal fluctuation across the menstrual cycle. Prospective diary studies demonstrated that around the time of ovulation, we increase our desire for sexual activity. We may have also an increase very close to menstrual bleeding due to the congestion of the pelvis, to the dominance of the androgen, and to many reasons they are studied at the present moment. But most importantly, we know that usually during the luteal phase, we have a significant impairment in our ability of entering sexual intercourse due to our sex drive, instinctual sex drive. So we are human beings, so we decided to have sex with our partner any day, of course, of the cycle, but for sure the cycle is modulating, and probably this is because it's modulating also other aspects of our well-being. For example, pain threshold, but also premenstrual well-being. And so there is also another hormone entering into action that we have studied a little bit less, but we believe is important. That is progesterone, the hormone that is typical of the luteal phase and also the hormone of pregnancy, as you know so well. And what we know nowadays that probably this ability of progesterone to shut down a bit the drive, the mental drive and behavior of women is due to the metabolization to a class of molecules that are so important for mental health. They are neurosteroids, in particular allopregnanolone. We have published many years ago with Professor Genazzani. I was presenting in Boston 20 years ago, a correlation between this metabolite we were able to measure that time in Pisa in collaboration with Pavia in the blood, allopregnanolone, with a score very common in our practice that can measure different domains of the sexual response. That is the female sexual function index. And you see that the entire score, and in particular desire, was significantly related to this steroid during the luteal phase. And so this is extremely interesting. And the only component at that time we were not able to correlate is pain, meaning really that the periphery for pain is quite important. And this is something that is due to the trophism probably of the organ and not to the drive within the central nervous system. And I was pleased very recently to publish this review article with a group of friends. They are psychiatrists in New York. The leading author is Leah Sasser, but is the group of another nice friend of mine in North America, that is Sheryl Parrish, that she has studied with us together with me and Sheryl and Jim and all the other, the process of care of female sexual dysfunction. And we were together discussing this idea that we don't know so much about this comorbidity between female sexual dysfunction and the most severe form of premenstrual tension, we may say, that is premenstrual dysphoric disorder. So something happening really in the luteal phase. And you see that the data we have, they reinforce our data on allopregnanolone. They reinforce the idea that the mood and therefore serotonin and other neurotransmitters and neuromodulators involved in psychiatric condition and psychological disorder, they play a crucial role. So there is a common etiology, and probably also some medication should be studied more, and we should record in the medical history of our patient any single psychoactive agent that in some way you may affect female sexuality, especially if you're using for mood disturbances. And you see there are also other medical comorbidity that confirm what I told you at the beginning: nicotine dependence, metabolic disorder, and obesity. They are the medical link between these two conditions and all other aspects that Sheryl will discuss. But we have to understand more. One problem also is related to the androgen. You have seen before, I didn't show you so well, that before the peak of estradiol, we have a peak of androgen, because there is no estradiol within the follicle if before we don't have a significant amount of androgen to be aromatized to give origin to the pre-ovulatory peak. And you see that we know since so many years, this paper was published in JCM back in the 90s, that when you get older and you still ovulate, your ovary is producing less androgen than when you were young. So the fact that androgens, they are going down with age, that is a concept that is quite well known in the literature, is true. But remember that also the ovary is producing less androgen, especially at the time of ovulation. And this is interesting to me because it can explain us why women after 35, 40, they start developing so many sexual problems, in particular, low sexual desire. Indeed, there are many conditions. They are related also to androgen insufficiency, not only aging, the aging of the ovary, the aging of the adrenal, but also other aspects. And I want to point out your attention, for example, to the chronic use of glucocorticoid therapy. And you know very well that this treatment, they are used in rheumatic disorder, autoimmune condition, painful situation. You have a strong modulation of the adrenal axis, and you modulate really also the androgenic compartment. And so this is something we should take into consideration. Then if we want to consider other medical and OBGYN aspects, think about the use of GnRH analog. Of course, we don't do for so much time, but in some categories of patients, they can be a real killer because they induce a chemical menopause that can exacerbate some problems that women already have. And then there are some conditions. I was quite curious during the last few years. There are hyperprolactinemia and hypothalamic amenorrhea, and I will spend a word on this in 1 minute. But just to end up the story of the testosterone, what I believe it's essential for you to understand that when we want to decode what is happening throughout the aging process of women, especially following 40 years of age and even further during the menopause, is that nowadays we have to consider both endocrine events occurring to the woman. The menopause events we know so clearly related to lack of estrogen, okay? And on the other hand, the aging process that is related to the lack of androgens. And probably many of the climacteric symptoms, including, of course, sexual symptomatology, they are related to both deficiency, or we may say insufficiency, of androgen. And the paradigmatic condition from a medical point of view that highlight this is the new definition we have of a very old condition that we studied on the book that was related to estrogen, that is vaginal atrophy. But nowadays, we don't name vaginal atrophy anymore. We name genitourinary syndrome of menopause. And why we name in a new way? There are many explanations. Maybe Sheryl can say better than me. But the reason is that we want to encompass the whole constellation of symptoms, including sexual symptoms, and not only dryness and dyspareunia, but also either dimension of sexual well-being, arousal and desire, and to encompass the idea that these signs and symptoms, they are due to a decrease of both estrogen and androgen with a modulation of the age. And so I think this is important to keep in mind. Focusing on what I already anticipated, that these two different conditions, I was reflecting with another friend of mine, that is Alessandro Genazzani. During the COVID pandemic, we had more time to discuss, as you can imagine, and we were sharing some ideas on this hormone, and I will tell you why in a minute. We know very well that prolactin is a neuroendocrine clue in sexual function from many reasons, and there are menstrual cycle fluctuation. We know that there is a fertility window that is involved and modulated by prolactin, which is there are several conditions. They are very frequent in reproductive medicine, such as miscarriage, unexplained infertility, menstrual dysfunction, etc. They can modulate sexual function and desire as well. Pregnancy and breastfeeding, we know very well that for some women, sexual function is very difficult during lactation, especially if postpartum depression is comorbid, and so. And we said that this biomarker, it's a sort of link between organic and psychosocial factor, because we know very well that these aspects, they can modulate prolactin release. So we speculate together that this hormone may represent a soft marker for so-called reproductive distress that in some way can interact with sexual function and behavior. And I've seen in the literature that some signal of this is emerging. We start from this background cartoon that I produced some years ago, summarizing what we know, that prolactin is an essential hormone for sexual response because, first of all, is controlled by a neurotransmitter in an inhibitory way, that is dopamine. Dopamine is so crucial to modulate anticipation, motivation, performance, and reward. Prolactin is increased following orgasm, so can modulate that refractory period that is not so well described, is described, but we know that women, they can be polyorgasmic, but for some women, this is not the case. So prolactin may contribute to inhibit sexual desire and arousal, and we know that prolactin directly or indirectly reducing estrogen can reduce vaginal receptivity, reducing lubrication and giving pain, and the model is lactational amenorrhea. But last but not least, the prolactin is related in some way to another very important neuromodulator in reproductive medicine, that is oxytocin. As you know, oxytocin is strongly controlled by dopamine, and oxytocin entered the three phase of to protect our species, because is released in orgasm, is released at delivery, is released when you lactate. And oxytocin, most importantly, is responsible of many neuroendocrine reflex that facilitate satisfaction in the brain, but promotes as well lubrication and orgasmic contraction, but it really stimulates bonding and relationship. And so this is another link, putting the body and the mind together, and prolactin is part of this business. But another very fascinating concept is when you have a high level of prolactin, even mild high level of prolactin, you reduce significantly, as you know very well, the pulse of GnRH. So the release of GnRH is not efficient, and you can develop anovulatory infertility. But the information that is most crucial to my discussion now is the fact that increased serum prolactin level reduce significantly another substance that is so much investigated nowadays in reproductive medicine, that is kisspeptin. Kisspeptin is really a signal that is crucial for GnRH, especially when we enter puberty, because kisspeptin is permitting both reproductive function and sex. And what we know is that kisspeptin is not doing only this, but is having, at the level of the central nervous system, a general effect on many central circuitries. They are involved not only in sexual behavior, but in other aspects they are related to sexual behavior, such as social behavior, anti-fear. It's a potent anxiolytic and antidepressant, and is modulating also the animal part that is in between us, the olfactory circuitries, because it's really a basic olfactory signal that you may modulate by the presence of kisspeptin. And this is the reason why I believe it's important to share. And this is the first study, and is a study that was conducted by another good friend of us in North America, fantastic person, that they are investigating the role of this kisspeptin against placebo in modulating hypoactive sexual desire disorders. So this is really fantastic, because it's the link between reproduction and sexual medicine. Of course, this is a randomized clinical study only on a small group of premenopausal women, but you see that you may study really the brain, the real life. You can see what happened when you do what? When you administer kisspeptin against placebo to modulate sexual and attraction brain processing, and you can measure that. And you can visualize in the brain, and you can measure also with scales we use to measure, for example, sexual aversion, distress, etc. And you recognize the question that we do to, for example, understand what happened to desire, what happened to arousal, what happened to orgasm. And you may absolutely correlate what is happening, for example, in the hippocampal activity response to erotic video, together with this score. And you see very clearly that when you treat with kisspeptin, this is something happening. So I think this will be a new era for us to investigate, and reproductive medicine will be strongly linked to this sexual medicine field. As I told you, another very interesting condition is hypothalamic amenorrhea. We know since many years that these women, they may have a low androgen. We decided together with a student of mine to investigate these women. They have different phenotype of functional hypothalamic amenorrhea. And why we did that? Because we believe that was a good model to have women, they have the same impairment in the psychosocial background, but they have different degree of impairment of menstrual function, because we know that there are some women, they are pure functional hypothalamic amenorrhea, so they don't have really gonadal function, whereas there are some women, they have the so-called multifollicular ovary. They have an inhibition at the level of the central nervous system, but their ovary are still active, and they have a little bit higher level of LH, as you can see, with an impairment, amenorrhea, but a little bit more of androgen and estradiol. It's extremely interesting to see this data to me. Why? Because you see that when you consider functional hypothalamic amenorrhea, there is a little but significant higher sexual function in women, they have an underlying PCOS phenotype in comparison to women. They have pure hypogonadic and hypoandrogenic, hypoestrogenic functional epithalamic amenorrhea. Distress is the same because these women, they are really highly distressed at many different levels. But it was interesting for me to observe that when you put together the whole group, it's interesting to see that the measurement of androgen, especially androstenedione, we do not consider so much. We always consider total testosterone. We always consider the HEAS. You know, this is a question of methodology. So, but anyway, in this study, it was striking to observe that the hormone androgen that was more correlated to the symptom, it was really androstenedione, and most importantly, that LH was correlated to a better sexual function, meaning that if you drive the gonad with a LH, you, of course, produce a little bit more of androgen in the follicle and a little bit more of estradiol, and this may play a role. So I believe we should study better this syndrome, and this is a good piece of data to support the idea that androgen play a role at any age, also in women. They are younger, especially when they don't bleed. Another very important point I want to make, talking about reproductive condition, is the paradox of polycystic ovary syndrome. You will agree with me that since the crucial role of the role of testosterone is so crucial in several domains of sexual response, these women should have a fantastic sexual response. Whereas we know that the clinical sign of hyperandrogenism, they have an impact. So this is a very difficult syndrome to be studied, and side effects probably outweigh the benefits when we are at higher level of testosterone. And this is another aspect we should study. And indeed, when you look at the literature, there are very mixed results. We have not so many studies because it's very difficult to control for all the variables. And what we realize that is not the level of testosterone that we should measure, is very difficult to create a link between something biological, and we should look more at controlling the symptom of our patient, the hyperandrogenic symptoms. So to improve sexual attractiveness by reducing hyperandrogenic sign is more important. And in order to better understand how these clinical signs are relevant, I want to share another study that came from my group with the help of another good friend of mine in North America, a psychologist, that is Alessandra Arellini. She spent the time in Italy 10 years ago, and we had the idea to study sexuality in polycystic ovary syndrome, dividing our patient in two different ways. The same patient, okay? The one, they had a clinical sign of hyperandrogenism towards against the one they didn't have, and the one in which we were able to demonstrate biochemical versus non-biochemical, because as you know very well, you may have hirsutism and acne even without a clear increase of androgen level. You may have hypersensitivity at the level of the receptor. And what we found, in my view, is extremely interesting. That one of the domain, you know, there are some instruments, I think Sheryl can say better than me on this topic, but there is an instrument I like very, very much, that is measuring sexual cues that was developed by Cindy Maston, another great sexologist in North America. She's in Canada, based, I think she was based at that time. And she developed this instrument that is quite interesting because it helps us to pick up in clinical practice. Women, they have some cues, they are more related to endocrine organic stimuli, so visual proximity and erotic explicitity. Towards sexual cues, they are more related to love bonding, romantic implicit. And you see that when you study a population of PCOS, you see they are the one with clinical sign and not with biochemical hyperandrogenism. They are reporting more something that is related to circuitries they have been described attached to androgen in the brain, okay? Meaning that probably is the sensitivity of the brain that is important, or probably is the intracrinology concept. So nowadays, when we want to study a relationship between hormones and what is happening to sexual function, we don't have really probably to consider the blood sample, but we really need to consider what is happening within the cell. And this is the reason why, in my view, at the end of the day, what is important in practice is to interview our patient to try to figure out which symptoms they have, and to try to help them with the best strategy. Last, to end up my talk, I want to make a comment on something extremely important in reproduction that is happening nowadays. And this was already well summarized by an Italian friend of us, Pino Benegiano, that was thinking at that time in Human Reproduction Review about how we change, how sex and reproduction relationship has changed over time. And this is also due to something we do in reproductive medicine. On one hand, fertility control, and on the other hand, assisted reproductive technology, especially now that these techniques are so, let's say, more developed, and also many women, even over 40, even into the menopause, they can use, especially when they are early menopause. So we have a change in the relationship between sex and reproduction. You can have sex without reproduction. We can have reproduction without sex. And so this is interesting. When is interesting? When we try to understand the impact, for example, of combined hormonal contraception or fertility treatment in sexual medicine. It's biologically plausible, of course, that when you prescribe a combined hormonal contraceptive, you shut down the ovarian function. You may modulate as well adrenal production of androgen. You may modulate the bioavailability of both hormone, testosterone and androgen in general, and estradiol by increasing sex hormone binding globulin, by reducing the conversion of to estrogen from precursors, but also modulating the activity of androgen at the level of the receptor. And so if you reduce the 5-alpha reductase activity, you may modulate the androgenic effect. And this is important not only to treat hyperandrogenic symptoms, but is important to understand the consequence we have on sexual function and behavior, because we observe a change in the neuroendocrine balance in the brain. We observe a change in the urogenital trophies. Of course, not in all women. In the one, they are vulnerable. So our ability should be to recognize that those cluster of women, they are more vulnerable to this change. You will develop a new balance in your well-being. Some of these women, they will have an emotional and sexual imbalance, and probably we should consider mood disorder, other pain condition, they are there. And because in these women, these are the ones, they are most sensitive probably to the modulation of the estrogen and androgen milieu. And indeed, it's depending probably on what you gain with hormonal reproduction, because we have plenty of data in the literature suggesting that when you are achieving a benefit for body image, so go back to the model of PCOS to understand this, you may increase sex drive, arousal, lubrication, you decrease the pain, you increase the satisfaction. Why? Because you're doing something good to the body image, to the psychosocial aspects of the sexual response. Maybe you're doing less good to the estrogen and androgenic compartment, but doesn't matter because you obtain something significant for the woman. And last, reproductive condition I want to touch upon also because I want to acknowledge the work of another pupil of Professor Gianzani that was so smart in producing a cartoon that should let us think about the complication of sexuality, why it's so multidimensional. And it's complicated, but if you know, it's not complicated, because we have to consider what Sheryl will tell us on the fact that even a biological symptom, such as, let's say, pain with sexual intercourse, in the other most common condition in reproduction, in fertility life, that is endometriosis, that it's more or less 5-10% of women. 5-10% of women, they have PCOS. 5-10% they have endometriosis. You see that sexuality is always there. And we know that this symptom is organic. Of course, there is, endometrial tissue there being so painful. But then you have the whole bunch of other psychosocial aspects, they are relevant. And if you wait too long, of course, according to the personality of the woman, according to the type of partner, according to other stuff, you will have a vicious circle. And so my key message here is really that when we treat a condition in reproductive medicine, we really need to recognize early from the start that you have a sexual problem in order to prevent that and to improve sexual function and behavior. Because we can do that, because we have data suggesting that when we prescribe a combined hormonal treatment, we decrease dyspareunia, so the pain. But unfortunately, if we do that too late, we maybe do not increase the sexual desire, orgasm, satisfaction, and so on. And we have plenty of data now coming out also from group. They are really studying endometriosis, such as in Milano, the group of Professor Vercellini, suggesting that the pain is one of the dimensions of this condition, but all the other are strongly related, and we have to pay attention to the full story. And so I want to end up with this cartoon to give the floor to Sheryl, to reinforce also the importance in fertility clinic, in reproductive medicine, to, and probably in every period of a woman's life, their role to include the partner into the discussion. Of course, the paradigm of infertility is the one that has been more studied. We need to study more what happened, for example, to involve the partner in menopause. We have data we produce with Sheryl, but not so many, because remember also that female sexuality can be studied from a medical and organic point of view, but we should study at the same time the medical and orgasmic problem, and desire problem that male may have, and the setting of infertility clinic. It's really the golden moment to do that, because they are both our patients. And with this, I thank you very much. I hope you enjoy, and I give the floor to my dear friend Sheryl.
Thank you, Rossella, for that fantastic lesson. We will have a lot to discuss after. We have already collected several questions, but it's now my pleasure to introduce Professor Sheryl Kingsberg, she's a psychologist and behavioral medicine division chief at University Hospital in Cleveland Medical Center and professor at Case Western Reserve University. Her area of clinical specialization includes sexual medicine, female sexual disorder, menopause, pregnancy, and postpartum mood disorder, and psychological aspects of infertility. She is associate editor of Sexual Medicine Reviews and sits on the International Board of Menopause and Climacteric. She is past president of North American Menopause Society, and the International Society for the Study of Women's Sexual Health. She will talk today of talking sex and treatment approach. Please, Sheryl, you have the microphone.
Well, thank you so much. I'm going to share my screen. So first, let me thank you for inviting me. I have to say, I have always felt such an honor to Professor Genazzani for inviting me to Florence, but also for always supporting the study of female sexual health and knowing how important it is to the overall health of women. And for clinicians such as everybody listening to appreciate the sexual aspects of everything they do medically. And I couldn't say it any better than Professor Nappi, who has been a good friend for many years. We have grown along since being princesses, hopefully to queens. And it is always a difficult topic to follow Rossella. She's an amazing speaker, and so I am going to try to leave some time for questions because she's covered so much so well. So let me go right to the point of my talk is really to bring us back to the idea of sexual health and sexual dysfunction across the lifespan. And the fact is that we understand sexual function for women in many different models. The first model really is a fairly linear one that Masters and Johnson developed way back in the 1960s, looking at the sexual response, which they studied in the lab, from an invariant model saying that everybody starts with some psychoerotic stimulation that encourages excitement in the body that would look like vaginal lubrication, increased heart rate, perspiration, nipple erections, and this is true in both males and females. With enough psychoerotic stimulation, the body reaches a peak level of excitement called plateau that then triggers the orgasm, which is the release of all sexual tension in rhythmic contractions in the pelvic region, but orgasm is also stimulated in the brain. So all the neuroendocrine function is that Dr. Nappi talked about is absolutely true. And then the body moves to an unstimulated state called resolution. Now, in the 1970s, Helen Singer Kaplan discovered that really the most important organ for sexual function is in the brain. And so she altered that linear progression to say we need to start the idea of sexuality from the brain, which is desire. And that has created the interest in studying desire for decades since. So in her model, it's desire, arousal, and then orgasm. Now, it is important to, let me see if I can change my slide here. Hard to see. There we go. That in this female sexual response, there's an infinite way in which women will experience their sexual response. So although it is very linear with excitement, plateau, orgasm, for women compared to males, there is an infinite variety of ways to experience that response. And for clinicians, it's important to know that because many women will come into you and say, what is the normal way to experience a sexual response? And for some women, they may not be orgasmic every single time. And as long as for the most part, they are reliably orgasmic with certain kinds of stimulation, we want to validate and normalize that. For others, they may have different responses based on where they are in their menstrual cycle, or maybe from premenopause to postmenopause. And we need to educate women that that may be a normal change for them. Now, in this model, you can see that that woman A has multiple orgasms, and on a different occasion, that same woman on C may have a different response, or maybe she doesn't have an orgasm on a different occasion. That would be normal. However, if the same woman was woman B and plateaued and never reached orgasm, then we would consider her to have a sexual dysfunction. So it's important to know that even though there is a response that is fairly linear, there is a variable way in which women can experience that sexual response. The other model to consider is from Rosemary Basson, which really reflects the idea that that linear progression may not be true for many women, that spontaneous desire, the drive that Professor Nappi was talking about, that urge to be sexual, often is there, but maybe it's not. And that for many women, they may experience a sexual response with what we call responsive desire. And this often may happen as we age or as the age of the relationship expands. So somebody who would be longing for their partner in a new relationship after 30 years may not have that spontaneous urge to be sexual right off the bat, but that we wouldn't pathologize. We would say once they get started, if they don't rely on that spontaneous drive, then that would be a normal response. However, what I will tell you is that that's not always the case to say, well, that's normal. That's just a fact of aging. I saw a woman just yesterday, 60 years old, who was married 37 years, and she lost her desire about 5 years ago. So many women, many people would say, well, Sheryl, of course she's not going to have spontaneous drive anymore. She's been married to the same man for 37 years. However, 30 years ago, she still had daily drive and she still wanted to have sex with him a lot, but it was only after menopause that she lost that spontaneous drive and she was distressed by that. So even though she could have responsive desire, that is, once she got started, she'd say, that was great. She missed the wanting. She missed the appetite. It's like walking into your favorite restaurant, and no matter how much you want to feel hungry to enjoy that meal, you just can't feel that hunger. And that's a loss, and that feels flat to many women. And so even though you might say, well, yeah, the meal was okay, women want to want. And so that's the difference between spontaneous and responsive desire. Now, Dr. Nappi talked about that sort of biopsychosocial model in so many ways, but I want to really emphasize that point that when we're thinking about sexual function in males and females, it's important to think about the factors that will contribute to healthy and dysfunctional sexuality, and that they are overlapping. And when you're trying to think about, as a clinician, what might be causing her sexual problems and what do I want to do to treat it, I think it's really helpful to consider this biopsychosocial model, because that will help you say which component has been compromised that I want to focus my treatment. So on the biologic side, Professor Nappi already covered so many of the aspects in neurobiology and the endocrine function that will contribute to the importance of sexual function and the health of sexual function, basic sexual health, and also what are the factors in the endocrine system and neurochemistry that will contribute to sexual problems. And so keep those in mind. On the other hand, psychological factors that Professor Nappi talked about, for example, depression, absolutely can play a role in the loss of sexual function. We know the bidirectionality of depression. One of the greatest symptoms of depression is loss of sexual interest and sexual function. On the other hand, if you lose your sexuality, that can create depression. Sociocultural factors, your religious beliefs, cultural values absolutely play a role in whether or not you embrace your sexuality or whether or not you feel shame or embarrassment or fear that can contribute to sexual problems. And finally, the interpersonal aspect of a woman's life will contribute to her sexual function. She could have all the biologic urge in the world and be psychologically healthy, but if she is not happy in her relationship, if she doesn't particularly like her spouse, then she's not going to really have good sexual function. And so back to the basics of looking at the overlap, many of these factors could contribute to sexual function. But when you're thinking about treatment, think about which component has been compromised, and that will allow you to focus your treatment. Now, thinking about prevalence, when you think, well, not in my practice, none of my patients have sexual problems. Well, you're not asking if you don't think they have them, because we know that almost 50% of women will report some sexual concerns. Now, whether that meets the criteria of a sexual dysfunction that you would like to treat is a little different. And if we look at, for example, this is a US sample, but we know that Susan Davis has done the same research in Australia and other European countries, and Dr. Nappi has done this. You can see that the statistics remain about the same. and that there's about 12% of women, 12% that would meet the criteria of a sexual dysfunction, in this case, either desire problems, arousal problems, or orgasm, with desire problems being by far the most prevalent sexual dysfunction. And this is over the age range. So when we're talking about across the lifespan, and you think, oh, well, of course, older women are going to have sexual problems. Look at this, in the 18 to 44-year-olds, 9% met the criteria of having hypoactive sexual desire. It is the midlife women who had the most prevalent sexual problems, often because a lot of their menopausal symptoms are co-occurring, and or our baby boomers are not taking sexual problems lying down. And the oldest women have the lowest prevalence of sexual dysfunction because their distress may not be as great. If you are 75 years old, you may have the expectation that your sexual response isn't going to be what it's used to, or your partner's sexual function isn't what it used to be, and so their expectations may be lowered. But the rates remain high across all age ranges. So when we think about sexual problems, let's look at it in general categories. We won't get into the politics of which nomenclature is best. I think it's best to think about it as there are problems with desire, there's problems with arousal, which we break into genital and cognitive arousal, problems with orgasm, and pain with sexual activity. Often in our midlife women, it's GSM, or genital urinary syndrome of menopause. The definition of hypoactive sexual desire disorder is the loss of motivation for sexual activity, either that spontaneous drive or the responsive desire, and you have personal distress. With arousal, I just think it's easy to differentiate between cognitive, which is your ability to enjoy the sexual encounter, and genital, which is the difficulty to attain or maintain adequate genital response, which would be vulvovaginal lubrication, engorgement of the clitoris, and sensitivity of the genitals. And then orgasmic disorder, while most of us understand orgasmic disorder, which is the inability to reach orgasm, it also includes the reduced intensity. Many women will say it's so muted, it's barely even worth it, and it's very, very frustrating. And that it really occurs over all situations. So if a woman can reach orgasm reliably with a vibrator, which, by the way, many women will need to rely on as they age, that is not a sexual dysfunction if they can reliably reach orgasm, and more likely we just need to teach her how to incorporate that into partnered sexual activity. And speaking of partners, please don't forget to ask about the partner when you are assessing a woman's sexual function, because sometimes it isn't her, it is the partner, and the impact, the reciprocal nature in partner sexual function is absolutely the truth. Sometimes his or her partner's sexual problems is what causes hers. For example, erectile dysfunction may lead to her not being able to reach orgasm or losing her desire, or maybe her loss of, or her genital urinary syndrome of menopause, and the partner seeing her in pain every time they try to have penetration will have him lose his erection. So we want to look at the reciprocal nature. And this is a nice little pinball demonstration of that her desire might lead to his ED if it's a he, or his premature ejaculation could lead to her difficulty with orgasm. So please pay attention to the partner. Now, Dr. Nappi really talked about this tipping point when we're looking at sexual function in all areas, but this is particular in hypoactive sexual desire disorder. It's really helpful to know that our excitement, our desire or lack of desire, really is on a sort of a scale and a tipping point, because as a species, we should not want to have desire every single minute. If all of you out there were just thinking about sex right now, you wouldn't be able to pay attention to our lecture. So it's important that there is inhibition when appropriate. But for many women who have low desire, they either have too much inhibition, which would include things like serotonin, the opioids, endocannabinoids, or on the psychological side, relationship conflicts or bad experiences, or not enough excitation, for which we need dopamine and oxytocin that Professor Nappi was talking about, norepinephrine, or the positive experiences in sexual function. So we're trying to create a balance to move women off of inhibition or more towards excitation. So when we think about how we understand this from a biopsychosocial model, I bring us back to the 1980s when we first thought about depression as, before we had selective serotonin reuptake inhibitors, depression was seen as all psychological and all in your head. You go see a psychologist, pick yourself up by the bootstraps, and maybe get some cognitive behavior therapy, but that's what you do to treat depression. Once we had easy to prescribe medications like Prozac, which was first approved in 1988, then all of a sudden physicians accepted depression as a medical condition, and therefore it became a biologic understanding. We understood the neurotransmitters and we treated biologically. And so depression was treated either with pharmacotherapy, with psychotherapy, or sometimes a combination. Now we fast forward to the 2000s and we now understand sexual dysfunction in that very same way. For some women, psychotherapy will work, and I do it for a living, and I think it works very well. For others, pharmacotherapy will be an option, and for others, the combination. So please keep that biopsychosocial model in your mind when you're thinking that sexual dysfunction really is not all in her head, and all she needs is a glass of wine or somebody to buy her some flowers. That really is an insufficient approach to treating sexual dysfunction. So how do we treat sexual dysfunction? There are essentially three ways that we approach it. One is psychotherapy, which is safe and effective, but not for everybody. We have 2 approved medications for premenopausal women and some off-label uses for postmenopausal women. And then please do not underestimate the amount of unregulated, suspiciously marketed products that your patients are finding on the internet because they are looking for something, okay? The psychotherapy goals, I don't want to spend our time on, just know that it is essentially cognitive behavior therapy or mindfulness-based therapy that can be very effective in changing women's approaches to how they see themselves, how they see a sexual encounter, shifting from the negative to the positive. There are many valuable ways that we can approach improving sexual function in women, even if they have a biologic contribution. When we think about pharmacologic options in the US, there are 2 approved medications for hypoactive sexual desire disorder. That's flubanserin and bremelanotide. It is also approved flubanserin in Canada for postmenopausal women up to and including age 60. Flubanserin was really touted. It was approved in 2015 as the female Viagra only because it was approved as the first drug for women. But it really is a CNS drug, and it is a mixed postsynaptic 5-HT1A agonist and 2A antagonist. So it has pro-sexual effects, essentially improving and boosting dopamine while inhibiting serotonin function. It is a 100 milligram pill taken at bedtime. It often takes 12 weeks for it to take effect. So for women, those of you who are able to find it, please know that it takes at least 12 weeks for women to experience an effect. There used to be an alcohol prohibition. That is no longer the case. Now it is, if you're going to have your glass of wine and have 1 or 2 glasses of wine with dinner, wait 2 hours before you take your bedtime dosages taken at bedtime. Or if you're going to really have a big party and have a lot of alcohol, skip the dose. Contraindications, hepatic impairment, or the use of CYP3A4 inhibitors. Common adverse effects, dizziness, sleepiness, nausea, fatigue. And then there is bremelanotide, which is approved in 2019. That's an interesting on-demand subcutaneous injector that is a melanocortin receptor agonist. And it's on demand in that it works within about 45 minutes of injection. and lasts about 16 hours. So it also induces sexual desire. It's a 1.75 milligram dose administered. And again, it's as desired. So you take it once or twice a week or once or twice a month, depending on your interest in having desire as it occurs. And it is not indicated in postmenopausal women. The contraindications are uncontrolled hypertension. The most common adverse effect is nausea in about 40% of women who are in our trials. They experienced nausea, only about 8% dropped out. It usually goes away after the first or second dose or within about an hour of taking it. And then we have testosterone, which Professor Nappi talked so much about, but we think we need to think about this for our postmenopausal women. There's a global consensus that 12 international societies all signed on to, looking at the fact that the data will support the use of testosterone, exogenous testosterone, for the indication of hypoactive sexual desire disorder in postmenopausal women. The International Society for the Study of Women's Sexual Health published actually clinical practice guideline, because since it is off-label in every country except for Australia, you need to know how to dose it and prescribe it. And so we have done that. It is to bring women's testosterone levels back to what they were in their premenopausal years, which is typically 1/10 of a standard dose of the male FDA-approved products, or essentially about 300 micrograms per day. We do not support the use of compounded unless that's the only way you can get it. Certainly not pellets, which give you these super physiologic doses, or IM injections, and not for oral formulations. So the dosing is about 1/10 of a tube. I happen to have one, actually. This is a generic tube of, we use about 1/10 of this. It should last about 10 days or 2 weeks. And the resealable are easier. And again, it takes about 12 weeks to show an effect. You want to follow up to make sure that if women think a little is good, a lot is better, that you keep them in that normal premenopausal range. So you need to follow up with some blood tests. You cannot measure their testosterone levels to know whether they have hypoactive sexual desire disorder, but you can measure to make sure they are in the normal range. And then finally, the problems of orgasm and arousal disorder. We have no pharmacologic options to treat these conditions yet, but we do know that cognitive behavior therapy and mindfulness-based therapies and certain sex therapy techniques work really well. Directed masturbation, sensate focus, which is essentially developed by Masters and Johnson before mindfulness was a term. It is really a lot of mindfulness focus of a gradual exposure to sexual activities to reduce anxiety and keep people present. Systematic desensitization. We use vibrators for orgasmic disorder. We use dilators for vaginismus, which is the involuntary tightening of vaginal muscles. And as women age, please pay attention to the fact that their nerve endings may require more vibration when they didn't used to. And this is not to help, this is to help them educate their partners that their partners are no longer ineffective, but their bodies have changed. And then finally, we want to talk about dyspareunia, or pain with sexual activity. Typically, for postmenopausal women, it is going to be due to genitourinary syndrome of menopause, which Professor Nappi already talked about, so I'm going to skip over. But please pay attention to using one of these images in your clinical practice, because women will say, why is it painful now? And this, I'm telling you, a picture is worth 1,000 words. When you show them the difference in their vagina and their vulva, for what happened after they had a loss of estrogen, they'll like, well, no wonder it hurts. No wonder it hurts. And I think that can be very helpful in providing treatments, since local vaginal hormone therapy or spamophene can be very helpful. Here are our order of things to treat for GSM. You can certainly use dilators when there has been tension and now the development of vaginismus. We want to use lubricants and moisturizers, and we can use hormonal vaginal estrogen or vaginal DHEA, ospemifene. The lasers are still under a sort of study. We need to do more randomized controlled trials with lasers. And so my last comment is, please consider using this POSIT model when you're thinking about treating sexual problems in your clinical practice. If you say, I'm not an expert, but I'll leave it to Professor Nappi or Dr. Kingsberg, please pay attention to the fact that if only giving permission for women to be sexual, that they are entitled to be a sexual person and or to ask you about sexual concerns, and then you can refer, you have already done them a great service. You can offer them some very limited information, show them a diagram, show them their vulva, or give them some websites or information. You can make specific suggestions. And at any point you feel like this is too much for me or I have 12 minutes, give them a referral either for psychological therapy to endocrinologist and or to a pelvic floor physical therapist. There are many ways that they can be treated. If all you do is ask, you are a hero. So I will leave it at that. I will stop sharing my screen if I can, and I leave it to some questions, and I appreciate the opportunity to talk.
Sheryl, thank you. The talk was fantastic. You know, we are remaining we reached the biggest number and we are remaining such there. We are not moving. Everybody is still here. Now we have the question. We have received several questions and I would like to start. I will make the question starting from one to the other, but you can also answer to the question raised for the other person. Then Rossella, she's one question about contraception effect and sexual desire in function of the age of the patient. Is this more a problem in the younger post-adolescent life, or in the patient already in more advanced fertile life?
This is a very good question that I have to tell you has not been addressed so properly. Really because of the reason why I try to express to you, meaning that in the youngest, you have many more extra contraceptive benefits. They have an impact, for example, on body image, on other dimension of femininity, such as pain, for example, etc. And therefore, you may achieve some benefits. For example, in the older woman, of course, you may have the benefits that you don't get pregnant if you don't want to, or you treat heavy menstrual bleeding. But the situation, the endocrine situation that you have in a woman that she's already, let's say, 43, 44, 45, is probably completely different in terms of estroandrogenic milieu. And therefore, there are mixed results. If we look at the data that were published, you know, I didn't have the time to address everything.
No, but
you know, you see that there is no a single advice to say, okay, you give this to young women, you give that to old women, you select this estrogen in comparison to this progestogen, because every single woman is different depending on the biopsychosocial effects of the contraception by itself. So we cannot say that different ages react in different ways. Is that particular woman?
Thank you. And then now one question for Sheryl, something very interesting that is rising here, that you have mentioned sex therapy. And the question is the changes from vibrator use to use of a partner make easier or make more difficult the correction by the sex therapy?
You say, is it better to have the therapy alone or with a couple?
No, I think, no. I understand the question as, you know, you can achieve some results with vibrator during sex therapy. The difficulty is to transfer this one from when you have a partner.
Yes. that is, that's the hardest part about teaching somebody to use a vibrator, is to how to incorporate it with the partner. And it is really, again, using your best psychological effort from the clinician to the patient, and the patient to tell her partner, which is to make it seem like it is an enhancement as opposed to a fix for a problem. And that we must change the language, and maybe this is just in English, but the idea of a vibrator as a toy is not accurate. We look at a vibrator as a sexual tool, and that the idea that it is just for play is not true. We don't think about Viagra as a toy. We think about it as a sexual tool to help men function with their partners. And we think about vibrators the same way. It is a necessary tool, particularly for older women, to be able to have an enhanced sexual experience. And I will tell you, their partners are very appreciative when they see the desire and a huge orgasm on their partners, as opposed to that look of frustration. It always pays off in the end.
Thank you. And then now we have from Zainab Kudari Ali a question for Rossella. Is there any role for hormonal treatment for management of vulvodynia, vaginismus, and dyspareunia?
For dyspareunia, for sure, even though, as Sheryl told you, it's very common to have an hypertonic pelvic floor in women with dyspareunia. And most importantly, this hypertonic pelvic floor is even present when you have a vulvodynia, because it's a defensive response of the body to the experience or the anticipated experience of pain. We had experience by using local estrogen therapy in women. They had vulvodynia associated to interstitial cystitis. We published this in Gynecological Endocrinology some years ago, and it could be useful, because you should keep in mind that vulvodynia sometimes is the result of, in some cases, in young women, of low dose COC used. In particular, in some women, they have a vulnerability, a genetic vulnerability. Some people in North America, first author, I think, is Andrew Goldstein, studied the gene polymorphism of women that develop this vulvodynia following the use of COC, meaning that, of course, does not occur in every woman, but we have to recognize these women. And we can use both estrogen, but I use a lot of also testosterone compounded cream, 2%, we prepare 2%, or now we are using a lot of vegetable androgen that we are studying now in Italy, in order to modulate the pain threshold in vulvodynia. I have more experience when they are comorbid with interstitial cystitis, but we have some data also in vulvodynia. So you can try, not always work, but always together with physiotherapy of the pelvic floor.
Thank you. And Sheryl, a question for you is that one from an anonymous. How do you differentiate between genitourinary symptom of the menopause and hypoactive sexual desire disorder?
Well, actually, we have a paper coming out in Climacteric called The Yin and Yang. Thank you to Professor Nappi for paper, the yin and yang of GSM and hypoactive sexual desire disorder. They often overlap, and they are difficult to tease out. Read the paper. We're happy to send you the copy. That looks at how do you differentiate? Is it the pain that caused the low desire, or is it the low desire that if you don't have interest, you develop pain because you're not aroused? And so it is not hard. You can do a little bit of screening, and you should be able to tease it out, even if they co-occur. You want to treat the right one first.
Yes, certainly. Thanks. And then one from Jorge Ramirez, Rossella. How do you manage sexual desire in IVF and assisted reproductive technology treatments with so many hormonal variation and less mating cycles?
This is a very good question. I have to tell you that since I have the psychologist in my team, my life is better, meaning that, you know, these fluctuation of hormones are inevitable. As you know very well, unfortunately, we really inflect the natural sexuality of these people because, you know, in some cases, they have to practice abstinence because otherwise maybe they can have pain, they can have trouble, they should donate the sperm so they cannot do sex, etc. And in my view, if you help your patient by doing a nice talk with a psychologist that understand of sexual medicine, that reassure you that this is just for a period of time, that help you to stimulate non-sexual intimacy of the couple, you can have beautiful, beautiful results. The problem is when you do not address this issue at the very beginning. Keep in mind that some people, they stay, at least in my country, 1, 2, 3 years before going to a IVF center to ask for help. They arrive there, they are devastated. They are over 35, and they are overstressed by this situation. And so, you know, they just want to have a baby right away. They don't give a damn about their sex. And this is something we should address at the beginning because they really need to rebuild a little bit their couple, because maybe they will succeed to have the baby. But keep in mind that the baby is beautiful when you are in a relationship with that two people. And I have to tell you that I see so many patients, then they split during the technique, and this psychological counseling is very important also to avoid the dropout, because so many people following the first cycle, they say, okay, this is too devastating me, you know, and I stop. Whereas if you have somebody that is helping you, you can do a lot of good. So we should include a sexual approach from the very beginning in IVF center, because this is not trivial. This is the real truth of the people.
Certainly, I totally agree with you. Sheryl, you want to add something?
Yes, so I am the psychologist in our fertility program, so I wholeheartedly agree. I have to say that ironically, sex for procreation does terrible things to one's sex life, right? It is, they're supposed to be for procreation, but I have to say that is part of the education, is to validate and normalize the fact that they will lose their desire. And that doesn't mean that they've lost their attraction for each other, because that's somewhat one of the reasons for the split, is they say, we don't even want each other anymore, so maybe we should split up. And they need to understand it is about the pairing of failure and sadness with sex that has created this problem. And so one of my assignments is for them to have lovemaking different than penetrative sex at non-ovulatory times, so that they remember what sexuality and lovemaking is, as opposed to trying to make a baby.
Absolutely, absolutely, very important. This is also for the male sexual behavior. It can have a very terrible impact also to necessitate to have ejaculation at the proper time, just at the moment of ovulation. We have also many, many problems, and I totally agree with the importance of the psychologist figure inside to the team. And now a question, Sheryl, for you. This is, have you considered the impact of the loss of sexual attractiveness after surgically imposed bilateral ovarectomy and hysterectomy? This is something will happen in many countries.
Yes, and also bilateral mastectomy when there's breast cancer. So it's a very interesting thing, because couples are terrible mind readers, but they think they are good mind readers. And so women often feel less attractive, or feel like their partner will see them as less attractive, when the partner is just trying to be patient with their partner so they don't approach them. And so that then confirms for the woman, see, he doesn't want me because he's not approaching me. And he, if it's a he, says, well, see, she's not ready for sex because she's not approaching me. And so there is this vicious cycle of avoidance when in fact there is attraction, there is desire. They just need to have a conversation. And so at that point, the most important sexual organ is your mouth, to be able to have that conversation about trying to restore one's sexual activity once there has been any kind of devastating surgery.
Yes, I think it's also very important the role of the surgeon. The surgeon, when they have to speak with the patient of the impact of hysterectomy and also on the ovarectomy, on not only on the hormones but also on the psychology, on the vision of each one of the other. The woman remained the same beautiful woman she was before. We have to explain that one to our patients. And
well, you also you need to make sure that they know about the loss of testosterone, right? Because many surgeons may not talk about the fact that they need hormone replacement, including testosterone, for many women who lose desire. So that's particularly for those younger women. But that sudden loss of hormones, which Professor Nappi, I'm sure, could explain, really is a bigger impact on sexual function than even a natural menopause.
Please, Rossella, you want to go on?
Yeah, I want to add something. There are data in the literature suggesting that it's also a lot depending on the condition the woman faces when she's hysterectomized. Because, of course, if you arrive there and you had heavy menstrual bleeding, horrible pain because you had 4 fibroids and you were in danger of something, and then you get rid of your uterus, okay? This is completely different story if you are hysterectomized without a clear symptomatology. There are some women that just remove the fibroids because the surgeon in some countries, they say, okay, you know, it's an empty sac. Why are you keeping on going with this uterus? And now we remove also the ovaries because you can get ovarian cancer. Of course you can get ovarian cancer and this is horrible, but as a Professor Genezzani said, counseling in here is essential. And if you remove the ovary and you had already maybe some condition in which we believe, let's say I've seen a woman, she was really a rheumatic patient, she was taking a lot of corticosteroid, she had androgen really down there, and she developed a tremendous post-surgical depression that she had a suicide attempt. So we really need to be careful because androgen, they play a role, not only the one from the ovary, also the one from the adrenal, also manipulation, endocrine manipulation. So we really need to counsel the patient.
Yes, and then now we have just 2 questions, one from Shanaz Jivraj and one from Nadas Fair, both on testosterone. The first one is, what would your recommendation be for a woman with hypoactive sexual desire disorder asking for testosterone but has abnormal renal function? And the other question was, what about testosterone for premenopausal women?
I can answer on the renal function because I don't know if Sheryl feel comfortable about that because she is a psychologist. But there are no signal really that is so crucial renal function. The signal we have, it's more on hematological condition and liver condition. I think depends on the case. As you know very well, we have experience with testosterone treatment, but quite limited, at least in my country, because we had never had implants, we never had, but there are no signal that that particular renal disorder is a contraindication in comparison to other conditions. It's more important liver and hematological disorder. As far as the type of treatment, I think Sheryl knows better, or I don't know if you want to answer, because you have more experience in the United States of the use during the trial probably, and or off-label, because we don't use so much testosterone off-label in my country, unfortunately.
And now, just a question for you, Sheryl. Do you know about the European situation of hormone therapies, of therapies for female sexual dysfunction?
Well, unfortunately, you don't have flibanserin available, and you do not have bremelanotide. I do know that there is a trial that will be developing that I think Professor Nappi is working on, actually, for Libido. So she can probably talk to you about it. We are going to be doing a similar phase 2 trial in the US, but not until you have started it in Europe. And that will probably be the best chance to get something approved in Europe for premenopausal women with hypoactive sexual desire disorder.
Yeah, that's true. We hope we can do this trial. Of course, we are still discussing the kind of protocol we have to use because, as you know, this kind of drug, they are a combination of one-shot testosterone that you take and you absorb at the moment you want to have sexual intercourse, combined with a PD-5 inhibitor that help arousal. And we will see if we will be able to conduct the trial. We hope so, because otherwise in Europe, it will be extremely difficult to treat women. And this is the reason why we do not address the issue, because doctors, they are afraid. They are not able to give advice, and they open the Pandora box and they don't know what to do. And unfortunately, in our country, it's not so easy, for example, to pay for the psychologists and psychotherapists. There is not in the National Health Service for this purpose. And so this is the reason why at the end of the day, we do not address sexual dysfunction.
One question, Rossella, still on part of your talk. Well, a question from Anna Paola Di Bello. When and why do you prescribe the Kingsberg?
We cannot prescribe at the present moment, my dear friend. I just always try to combine practice to research, because I know that the audience in Gynecological Endocrinology Society, it's also for researcher. And so nowadays we have this possibility in the United States. Probably they will enter the phase 3 trial. I don't know if Sheryl knows better than me. And we hope we can have Kingsberg. Also, as you know, Kingsberg has been studied as under investigation with other purpose, also for help women for some ovulatory dysfunction, etc., etc. So I think it's a drug that is under development for many purposes. And but the fascinating part of Kingsberg, it's really that is the biological link between reproduction and sexuality, in my view, according to the data.
Sheryl, do you want to add something on that?
It's too early to have any hope that there will be Kingsberg for the treatment of hypoactive sexual desire disorder. And I did read those 2 papers. I didn't realize they were friends of yours, but it's fascinating. And by the way, they studied this in men as well. And they showed that Kingsberg is not gender specific, that it has the same effect in males and females. And of course, we are waiting for the neurokine agonist to be approved, hopefully, for as a non-hormonal treatment for vasomotor symptoms. So that will be the next option in the US, we hope, for fezolinetant. They're waiting for hopefully approval soon.
Then it's a question also on genitourinary syndrome of the menopause during breastfeeding. Then genitourinary syndrome of breastfeeding. Can you, each one of you, want to make some comment?
I think it can happen, and we see a lot when women lactate for a long period of time, especially if they are taking a POP, contraceptive pill, and they are very lean, and you know, they do not produce enough estrogen in their body. It's very important to inform women that sexual function, you know, can be impaired during lactation. And if we inform the women, since it's so important to lactate the baby, and we know that this is something that women do also for cancer prevention and to establish a bonding with their baby, etc. Usually you may prevent. There are data out there by using exactly the same molecule that we use for GSM, for example, hyaluronic acid, other moisturizers, so you use lubricants, and you can use also low dose estrogen therapy. We are collecting now data on this, and it's worked quite nicely.
Thank you. And I would like now to read you a comment coming from the floor. Clara Zobbi, she's mentioning that one. Good afternoon. Do you think that at the light of the new study, especially for the passage to the menopause, it would be better considered for almost every woman hormone replacement therapy for at least 10 years should be for unhelp, also for sexual disorder? No, I think, this comment rising from the floor express the difficulty that the people had until now with WHI, with all this study, smaller amounts, smaller time for the treatment, while a lot of data rise in favor of possible, if a woman, she can do a possible treatment for a sufficient time to help her in the daily life. And then now another question, we're approaching to the end, dear friends. And then one question, I don't know, Sheryl, if you have an answer on that one. Please give your opinion regarding the role of laser and other energy providing machine in cases of low sexual response.
Well, it's not going to be low sexual response, it's going to be pain. The lasers really have a place potentially for GSM. And we really need to do more, large randomized controlled trials. It may be that you need to prime the vagina with local estrogen first anyway, and they often need repeat, and they're expensive. And so there may be a role, particularly for women who are absolutely against using hormones. And to the prior comment, yes, we need to change our model of thinking about hormone therapy, both systemic and local. But I think it's too early to really sort of promote those laser therapies as standard of care.
Thank you.
I agree with Sheryl 100%. We really need to consider what is GSM and what is the sexual response overall. And it's very variable, and we still need good data to endorse that. Of course, can be helpful for some women.
Rossella, question for you. Thank you very much for interesting report. Okay. What do you think about the possibility of using oxytocin as a method of treatment for sexual dysfunction?
As you know, oxytocin has been investigated in the past, and then the preliminary trial, they were stopped due to some side effects. The problem is that, it's a very potent molecule, and that, work at very, very low dose. And so I think we will go on in studying the oxytocinergic mechanism. I promise you that I will try to go on together with friends. But it's very difficult, to replicate what Mother Nature is doing, because you realize that oxytocin is just a peak. It's not something that stay in the body for long, because oxytocin it's like when you have contraction at delivery. If you don't have the relaxing phase, you will die. Meaning that cannot stay on the receptors too long. It's just a peak at the time of arousal. It's just a peak at the time of parturition, etc. So we will see. It's too early.
We need relaxation also. And then now a question, Sheryl, for you. What's your advice for pregnant women regarding sexual activity?
Well, that's a good question that you need to make sure you talk to your obstetrician about, because there are some women who have high-risk pregnancies who really need to be very careful. Particularly, for example, oral sex has some data that you need to be careful. But most women, you have to think about, first trimester, second trimester, third trimester, whether in fact there is increased desire, decreased desire, which will depend upon whether you're, throwing up and have morning sickness, or whether your drive level for many women will increase, and it can change from first trimester to second trimester. Many women won't have much desire in first trimester, but it increases in second trimester. And by the time you are, uncomfortable and can't see your ankles in your third trimester, you may not want to be doing much of anything regarding sexual activity. So it is, as long as your obstetrician says, okay, and you have interest, then feel free. Otherwise, some women will say, I just can't even think about it. We do have a lot of publications on pregnancy and sexual function and dysfunction and postpartum sexual function and dysfunction. There's a lot on that topic as well.
Thank you. Yes, a very crucial moment also for the couple life. And then a question for Rossella. I wonder if there is an interaction between adipokines and sexual motivation.
A real interaction between adipokines and sex drive is not there. But as you know, there's been studied a lot in inflammation, and all these molecules, they modulate the impact that the metabolic function has on sexuality in terms of genital arousal. We have some data suggesting that women, when they are inflamed, they may have, let's say, a metabolic syndrome of the genital, and therefore it's more difficult to release an adequate amount of nitric oxide, and they can develop poor lubrication, etc. But we have to study more this topic because, as you know, there are many other factors going on. There is an impact of age, body weight, distribution of the fat, because if you have a visceral fat, it's completely different than when you don't have the visceral fat, because adipokine, as you know very well, they express if you are metabolically healthy or metabolically unhealthy, and you can be overweight, let's say, and being metabolically healthy, and so your sexual function and behavior with menopause maybe will be okay because you have a certain amount of estrogen, you don't have so many hot flashes. Whereas the one you should consider more, they are the one having hot flashes, because the one they have hot flashes and they are obese, they have a significant risk, cardiovascular metabolic risk, and they may have an impairment of sexual function, even though they are obese and they have a high level of other estrogen produced by the adipose tissue.
Okay, then the question arising because the topic is very interesting. I would like to make you one, Sheryl, that one. After suffering of heart attack or stroke, many women and men are afraid to have sexual life. They're especially afraid of the moment of orgasm. How to manage such patients?
That is, everybody has that anxiety. It's remember Freud called orgasm the little death. And so that, it certainly is something to get the reassurance from your cardiologist, number one. So it goes back to the clinician giving permission again, and it shouldn't just be a gynecologist or a primary care. It needs to be whatever is treating you. And I would encourage any patient to ask, because clinicians, particularly cardiologists, they may be good at giving Viagra now, but they're not so good at talking to women about sexual function, and they don't think about women and heart disease, which is a leading cause of death. So it is not likely that they will, so education number one, the level of exertion in an orgasm is, kind of comparable to climbing a flight of stairs. And so if they are allowed to climb a flight of stairs, they should be allowed to have an orgasm. And I think making that analogy will be the fact that will cause them to reduce their stress. But they really should get that permission from their cardiologist too. But making the analogy usually helps.
Thank you very much. And then now we are at the end. We are now more 1 hour 45. We have still 190 persons with us. I would like to have a final comment on the topic, because sexuality is rewarding all our life. and then I would like we start Sheryl, you first, and then Rossella.
Well, I couldn't have said it.
Final vision from you, starting from the huge experience that you have in your professional life.
Well, my professional life has been enhanced by working with both of you. And so we create that biopsychosocial model. So please, know that it takes a village. You shouldn't have to feel like you have to do every part of sexual function. There are many of us that can help. You just need to ask. That is the biggest ask for me to any clinician listening. Just ask about sexual concerns. And then at any point that you feel it's out of your realm, make that referral. And now with telehealth, I have to say that the only silver lining of this pandemic has been you can refer not just in your little village, but you can refer, across the ocean. So please ask and refer at any point. And I appreciate being able to work with you for so many years now, virtually as well as in person.
Thank you, Rossella.
I'm a really good friend of Sheryl, because to me, the most important thing is ask because of the time. Because what I see in my practice, if that people, they suffer in silence for a long time, then it will be much more difficult to help them. So to ask is essential. And if we don't do that, then we contribute to that dysfunction. Because if we don't make a comment on how you feel about your sex life today when we visit a woman, when we see a woman for so many reasons. You have seen polycystic ovary, anovulation, infertility, pregnancy, menopause. Every consultation is, to see a woman and to meet a woman. And when you meet a woman, you should talk about also sexual health. And this is the duty of every physician working in women's health, and even in male health. And in any condition, organic condition, the patient always asks, how do you feel about sex life? This is just the solution.
Thank you very much. And your words of both of you remind me a fantastic friend, a psychologist, psychiatrist, medical doctor, also Iole Valdaroverde. She teach me sexology, and she educate me to ask to my patients. And since that moment, the quality of my professional quality was absolutely improved, and not only for each single patient, but also for their families, also for the couple. And then I think it's a fundamental step. And for that, ISGE have created that fantastic webinar with 2 stars of this world. Thank you, Sheryl. Thank you, Rossella. All our hearts are full of emotion this afternoon. Thank you for being with us, and to see you soon also in Florence. Then for all the person with us, next webinar will be on postmenopausal osteoporosis, promoting bone health from menopause and beyond. And we will have Antonio Cano from Barcelona and from Valencia, and Jean-Yves Regester from Liège to speak about that one, the 19th of April at 3 o'clock in the afternoon. And with Botticelli with us, I invite all of you to join the 21st World Congress of Gynecological Endocrinology in the magnificent scenario of Florence, 8-11 May 2024. Dear friends, see you soon. Enjoy the life.
Bye-bye.
And
Bye-bye.
thank you for being with us.
Thank you.
Thank you, Sheryl. Thank you, Rossella.
Sheryl, thank you. Have a good day.
Thanks.